So tonight we're very fortunate to have Dr. Michael Izard with us. He's a great friend of this support group and a wonderful contributor to PCFA. He works out of 4 hospitals, the Mater, Macquarie University, Norwest and Penrith. Nepean. Well, I nearly got it right.
So, my name is Michael Izard. I'm a radiation oncologist and I've been doing brachytherapy for something like 14 years. So, I still see stuff that I haven't seen before, but it gets longer and longer between the new events. This is for you guys. This is not for me. So, it's not, as I see it, my job to stand up here and blether for 50 minutes on stuff that I want to tell you. This is for you to tell me what you want me to talk about so that I can blether for 50 minutes about what you want to hear. It's not didactic. I don't use a computer. I'm not going to be showing a PowerPoint presentation and boring you to quietly nod off to sleep. I want this to be interactive. I want you to sing out and ask questions as we go. If you don't understand something, for goodness sake, say so. So what do you want me to talk about? The topic is brachytherapy, but I'm happy to be as narrow or as broad as you want for this evening. What do you want me to talk about with brachytherapy? So,
different types of brachytherapy.
Different types.
The profile of patients that fit the 2 types.
Suitability.
Suitability.
Recovery time.
Recovery.
Side effects.
Side effects.
You beat me to it, Les.
Something near and dear to everybody's heart, I suspect. As much as your prostate is near and dear to your heart.
The effectiveness compared to other treatments.
Effectiveness, results. David?
I'm still thinking.
The constancy of the side effects, does everyone have the same side effects?
Mm-hmm.
How does it vary?
So,
Repeatability?
variability and duration.
Yeah.
Variability, frequency perhaps. Yeah. Duration, sure.
When not to use brachytherapy.
Okay, that might go into suitability. When not.
Oh, good, Graham.
Hopefully that's, thank you. Oh, lovely. Well, I think this one's working so far, so. Okay. Is that enough to go on with?
That's enough to start.
Okay, so.
There was one more.
Yes.
Sorry, Michael.
Complementary medicine.
Complementary to what?
To what do you do?
Yes.
Supplement what you're doing.
All right. So that's not actually the topic of brachytherapy, but that's maybe how do you fit other things in around it? Is that what you're asking?
Well, it's a total approach.
Okay.
What you're doing.
Okay. All right. All right. Complete. CLE. Well, there you go. Okay.
Yeah.
Is there a backup treatment after the brachytherapy in case there's...
So what to do after it fails?
Yeah. Is there
Okay.
any option for that?
Next step.
Yeah.
Okay.
Can we just add one final one? Costs?
That one's easy. That's lots.
The availability of different types of brachytherapy at different hospitals.
That's not so easy for me to talk to because I don't work at multiple different hospitals, so I can't speak to what's available at Westmead or what's available at St George or at North Shore or at RPA or that sort of thing. So I can tell you what there is where I work, but what's available in different places will depend very much on who's driving it in those places and what they want to do there. Okay, so different types of brachytherapy. Basically, there are two types. There is a permanent and there is a temporary brachytherapy. Brachytherapy supposedly is ancient Greek, two words stuck together. So I've yet to meet an ancient Greek, and the Greek people that I've asked say they don't recognize either of the two words particularly. Telephone, television, distant sound, distant sight. Brachytherapy supposedly means close treatment or near treatment. And it's using one end of the inverse square law. The inverse square law is a fundamental law of physics for using radiation and radiotherapy. And the inverse square law says that the dose of radiation is directly proportional to the inverse of the square of the distance. And that's the only equation I'm going to talk about tonight. But translating that into English, think of a candle flame. You put your finger on a candle flame, you'll burn your finger. As you pull your finger away, the heat gets less. The heat is getting less with distance. And the physics of it is that the heat is getting less with the square of the distance. Now, if we take some measurements, if you've got your radiation source sitting here, or your candle flame for that matter, 1, 2, 3, 4, 5. I work in millimeters, so millimeters are the unit of my reference here, but in fact the inverse square law doesn't have a unit of distance. It can work in inches, it can work in kilometers, it doesn't matter. But the dose of radiation is related to the inverse of the square of the distance, so that's d over 1 squared. So at 1 millimeter away from our source, we've got d over 1, which is 100% of our dose. So that's our reference dose at that point. 5 millimeters away, it's now, the distance is now 5 millimeters, 5 squared. 5 5s are 25. And 1/25 is 4%. So we've lost over 4 millimeters. We've lost 96% of the dose. So there's a big drop in dose over a very short distance. And in fact, it's an exponential curve. And so external beam radiotherapy, the standard routine radiotherapy treatment, is given at that end of the inverse square law, whereas brachytherapy is given at that end of the inverse square law. And what that means, this is where we find it's not in it. It's mostly coming off. If there's your prostate and there's your rectum, and we're putting in a bunch of radioactive sources or substances or seeds or whatever into the prostate, the dose of radiation is coming out from those points but getting less, and that distance is enough that the dose falls away very quickly, so that we're not putting full dose of radiation on the rectum whilst we are putting full dose of radiation onto the prostate. One of the other issues with this is that there are areas within the gland that are getting more than 100% of the dose. The areas that are close to your sources are getting 120% of the dose, 150% of the dose, 200% of the dose. And so whilst you're looking to get 100% of your dose, cover that area there, the 120 is probably going to look more like that. So that's getting 1.2 times my prescribed dose. And there's going to be areas that are potentially getting 1.5 times my prescribed dose, or even 2 times my prescribed dose. And so when I say that a dose of brachytherapy, if I say that my prescribed dose is 145 gray, gray being a unit of radiation, there's going to be areas inside the prostate that are getting 150, 160, 190, 200 gray. And so there are areas within the gland that are getting significantly more dose than I'm prescribing to cover the whole gland. So if a bucket of water is useful to putting out a fire, then 2 buckets of water is probably going to be twice as useful. The potential, the care that we have is to make sure that we're not putting those high dose areas up against either the rectum at the back or around the urethra in the middle. So we have to be careful with those things. So, permanent and temporary. Well, they're exactly what they are labeled. A temporary implant, you're putting the radiation source in and you're leaving it there for 24 hours. A permanent brachytherapy implant, you're putting the radiation source in there and it's staying there forever. So the fundamental dose delivery is exactly the same. You're looking to cover the volume of the prostate with the radiation. But the time frame that you've got to do it is very, very different. Permanent brachytherapy is also known as HDR. Wrong. A permanent brachytherapy is also known as LDR. And a temporary brachytherapy is known as HDR. DR is dose rate. In other words, the speed with which, or the quantity of radiation coming out from your source. So low dose rate means that the radiation is trickling out of the source across a period of time. HDR means that you've got a much more powerful source pushing the dose out very quickly across a short period of time. So permanent LDR brachytherapy is also known as seeds, but a temporary HDR may be called by some people rods. Okay? What we're trying to do is put a source of radiation into the prostate to cover the whole gland and minimize the dose of radiation to the urethra in the middle and minimize the dose of radiation to the rectum at the back. So, why do you use one or the other? That relates to suitability. If you're using a permanent implant, you're using iodine seeds. And iodine seeds have a half-life of 2 months. That means it takes 8 months to put 92% or thereabouts of the dose into the gland. If you've got a faster growing cancer, if you've got a larger cancer, then that 8 months that it takes to put the dose of radiation into may be too long that the cancer can grow through that. If it's taking 8 months to get the dose of radiation in there and the cancer's turning over very quickly, which the more aggressive cancers can do, then it's not going to get you the control that you're looking for, that you want. And so a permanent implant, a low dose rate implant, is only suitable for the lower grade, low to intermediate grade prostate cancers that aren't particularly bulky, that have a low PSA, and the gland isn't particularly large. The size of the gland is relevant purely on a technical basis. Can we actually get the needles into the whole area, the seeds into the whole area of the gland? So, seeds are good for Gleason 6 or Gleason 7 for a PSA under 10 and a T1 or a T2 gland. So a gland that feels like it's minimally involved, either normal feeling on the finger or just a small nodule. Gleason 6 is 3+3. That means that the grading of the cancer is considered at the bottom end of the range of aggressiveness. Gleason 7 could be 3+3 or 3+, Gleason 7 could be 3+4 or 4+3. And I prefer not to use seeds on someone who's got Gleason 7 4+3. 4+3 means that they've got more 4 than they have 3, which means then that they've got a more aggressive cancer than if they had 3+4. And there's certainly been studies that have shown that there is a difference in control for patients with Gleason 4+3 disease over 3+4 disease. And so I prefer not to use seeds on someone who's at the higher end of the spectrum. And I'd prefer not to use seeds on someone with a 4+3. PSA less than 10 implies that it's a relatively small volume tumour. And T1, T2 also implies it's a relatively small volume tumour. So it's for the less aggressive end of the spectrum in terms of the types of cancers to treat. Size should be less than 40 cc's according to Medicare. And previous surgery. If you've had a TURP, if you had a rebore, instead of having a prostate like that with a little urethra sitting in the middle of it, you might have the surgeon scallop out the middle of the urethra. And if you've done that, I don't have anywhere to hang my seeds. And if that's the case, then I can't necessarily get as good an implant. So previous surgery can be a contraindication to using seeds. Not necessarily, but it can be. And the other thing is irritative symptoms. If you come to talk about treatment for your prostate cancer and you're getting up 4 times at night and you're running to the toilet because you've got urgency and you've got frequency, you're going to the toilet every hour and a half, and your quality of life is miserable because you're unhappy with that, I'm not going to make that better. All right? I might be able to fix your prostate cancer, but I'm not going to improve those symptoms, and I'm potentially going to make them worse. So someone who's got, we use a thing called an International Prostate Symptom Score, and so that score goes from 0 to 30, and someone with a score of more than 15 is someone who's bothered by, or potentially bothered by his waterworks, and I'm quite likely to make it worse for them. So if they come with a score of 15, then I'm quite likely to say it's probably not going to be the ideal treatment for you. One of the advantages of surgery over radiation treatment for prostate cancer is for that individual who's got bothersome symptoms. Because not only are they going to fix the cancer, or at least have a good crack at it, but also they're going to relieve all those irritative symptoms that that individual might have. On the other hand, if you're not getting up at all at night, and if everything is working absolutely fine and you have 2 or 3 Ps a day and you can take your time when you want to go and do it, then it's quite likely that if we want to look at a way of dealing with your prostate cancer, seeds might be a good option for you. So seeds are good for the lower grade cancer.
Michael, I had a fellow trying to tell me the other day that he was having brachytherapy and he was going to have all these gold seeds. Can you just explain to people about why you use a gold marker?
Gold seeds are also known as fiducial markers, and it's not radiation. The gold is totally inert. It's pure, inert gold that's used for us to aim our treatment. And so with external beam these days, we're giving much bigger doses of radiation. When I started, shock, horror, gasp, a long time ago, 25 something years ago, 26 years ago as a registrar, the dose of radiation that we were giving for prostate cancer was 60 gray. That was external beam treatment. And people were sort of umming and ahhing about 60 gray, and could you give 60 gray without giving too many side effects? And the brave people, the courageous people, were giving 66. And so we started to shave the corners off our fields and give a bit more than 66, and some people were going to 70. and some people went to 72, and nowadays people are going to 84 gray. So we're giving a much, much bigger dose of radiation, and we can, because we can shape the radiotherapy field now, that the rectum is not getting the 84 gray that previously it was getting 60 gray. But to help us do that, if there's the prostate, we need to put markers into the prostate so that we can say, right, that's our field. That's where we want to put the radiation. Because in the old days, we used the bony anatomy to work out where the prostate was. We said, there's the pubis, there's the sacrum, there's the hips. Prostate's probably in about there. And we had a field that sort of size. 9 by 9 by 10 was sort of the classic external beam radiotherapy field for 60 gray. And we were just treating this huge cube regardless of what was actually in there. You know, there's rectum in there, there's bladder in there, there's absolutely everything in there. But now the fields that we're using are down around 4 and 5 centimeters in size. And so they need to be in the right place, because if you've got a small field and the patient's rolled slightly, then potentially you've got a geographic miss. Potentially you're only treating half of what you want to be treating. And so now what we do is we put these little gold seeds, inert gold seeds in, to help us aim the radiation, so that on a day-to-day basis we can look at the patient. We can look at the patient's pelvis and we can say, right, there are the gold seeds. We need a 3 millimeter shift that way. We need a 5 millimeter shift that way. And so on a day-to-day basis we can put our radiotherapy more accurately. And by putting it more accurately, we can deliver the external beam radiotherapy more efficiently. But it's not brachytherapy. It's just a way of identifying the soft tissue of the prostate, not using the bony landmarks. So a temporary brachytherapy implant, HDR, is more suitable for the more aggressive cancers. So HDR will work for Gleason 6 through to Gleason 10. It will work for T1 to T3. It will work for a PSA out as far as you want to go. There's no upper limit. Having said that, if you've got a really high PSA, we're going to be very suspicious that there's disease elsewhere, and we're going to be talking about that. But there isn't an upper limit on PSA. We'd still have the size limits, and we still have the irritation issues, and we still have the TURP issues. So someone with a big TURP, I'm not going to be wild about doing HDR on. Someone who's got a miserable quality of life because they're running to the toilet all the time, I'm not going to be wild about doing HDR on. But a bigger gland, if I can get the needles into it, then size is no longer an issue particularly, but it certainly can be an issue if the bones of the pelvis get in the way technically of my being able to insert the needles in. If that's the case, I can use hormones to shrink it down. And that can take anything up to 12 months of hormones to shrink it down. If you've got a monster gland, it's not going to work, but if it's a little bit large, then we can certainly watch and shrink it over a few months. That potentially also has a benefit. Someone, quite regularly, I get people sort of say, it's not convenient for me to have my treatment right now. I've got to do this, I've got to do that, you know, we're moving house. Is it possible I can defer treatment for 3 months or 6 months? Yes, you can, but let's use some hormones just to hold everything in status quo. And in the process, that's also going to shrink the gland and make it a bit smaller. You've then got all the side effects of the hormones that go with that, which is a separate story. But we can time the brachytherapy to fit in with other things that there are around. The suitability comes a little bit against the results of treatment. And I would refer you to an article written by a guy called Peter Grimm in conjunction with about 20 other people from around the world. And it was published in January, I think, of this year, maybe February, in the Lancet Oncology, looking at the results of the different treatments for prostate cancer. And they identified over 18,000 papers that talked about prostate cancer. They identified 848 papers that specifically related to the results of treatment of prostate cancer in different places. And they then broke down those papers to compare the results of the different institutions to try and get an idea of the results of the treatment. And the results for me are breathtaking, because they broke them down by kind of good papers and good papers, by low risk, intermediate risk, and high risk. And so they came up with 6 graphs. And the good papers had a minimum of 5 years of follow-up, a minimum of 100 patients in the low risk and intermediate risk, and 50 patients in the high risk. Whereas the OK papers didn't necessarily have those constraints, so they could have less than 100 patients, or they could have less than 5 years of average follow-up. And for the low risk, they pretty well overlapped each other. For the intermediate risk, the same. For the high risk, the same. And they looked at the results. And what they got was basically that external beam and surgery kind of overlapped each other. And consistently, they had information that went from 5 years to 10 years. So they had multiple points that you could bracket in that particular group. And the brachytherapy patients consistently sat there like that. So brachytherapy works according to this group that Peter Grimm headed, works at least as efficiently in surgery and radiotherapy, and probably works 10 to 15% better for all categories, low risk, intermediate risk, and high risk. Now, the numbers on the y-axis varied. So obviously the low risk patients, that went from 80% to 100%. For the intermediate risk, that went from about 60% to about 90%. And for the high risk, that went from 30% to 70%. So the numbers changed depending on the different categories. And they also put in those figures, they did the cryotherapy, they did the HIFU, they put them all in there. They put robotic surgery in there. And consistently, the brachytherapy results were better than the others. Now, you can argue the semantics of it, you can argue the fact that this is not a meta-analysis, you can argue that each of these is individual papers with individual results, and there's a lot of patient bias and whatever else. But they've got probably the most efficient way of looking at the literature to try and get an idea of where these different treatments stand against each other. I was a bit slow in getting my paper to them, so they published that without including my latest review of my own patients. But consistently, my results are sitting in there. So I'm in the middle of the brachytherapy cloud. I'm certainly in the upper half of the brachytherapy cloud, and I'm very proud of my results. So as far as I'm concerned, brachytherapy works very efficiently and very effectively. That's the HDR. That's for the, but those, all 3 groups, the low risk, intermediate, and high risk, my results stand in the middle of the cloud, where you would expect them to be. So, how are we doing? What's the next step? Well, the nice thing for me is that quite often there isn't a next step. The nice thing for me is that quite often we've fixed the problem. And so the majority of my patients are pleased that their PSAs have continued under control. My figures have an average of 6 years of follow-up. That means I've got patients going out to 12 years. And so the results are certainly very encouraging as an effective treatment. But what do you do when the PSA starts to rise? Well, the first thing you do is nothing. The first thing you do is you sit and you watch it. Because one of the things that can happen is you can get this thing called a PSA bounce, where the PSA goes up and then comes back down again. And that can happen between 1 and 3 years after the actual delivery of treatment. And so everyone sort of runs around in a little circle saying, oh my God, my PSA is going up. But in actual fact, it's a bounce, it goes up and then it comes back down again. And so the first thing we do is nothing for anything up to a couple of years. If the PSA goes up and then continues to go up, then you have to turn around and say, well, this isn't a bounce. You know, quite clearly, it started rising and it's not turned around. So what we've got is some residual disease somewhere. That residual disease is either going to be in the pelvis or it's going to be somewhere else in the body. The higher the risk of the cancer, the higher the PSA. Sorry, the higher the grade of the cancer, the higher the PSA. That makes it more likely that it can have metastasized elsewhere. And for the most part, external beam radiotherapy is very efficient at local control. You give a course of radiotherapy. It can be external beam or it can be brachytherapy. But radiotherapy is very, very efficient at local control. You don't often get problems with recurrent disease in the pelvis. And that's lucky, really, because it's actually very difficult to do anything about it. If you do have residual disease, if you do have recurrent disease in the pelvis, following on from radiotherapy, you can't operate. That's not completely true. Of course you can operate, but what you get afterwards is such a mess that it's not worth the operation. The problem with surgery after radiotherapy is that there is a significant risk of having two bags, one for your bladder function and one for your bowel function, and living with that for the rest of your life. So generally speaking, surgery does not routinely get done following a course of external beam radiotherapy. Now, there are places around the world that are doing it, and you do come across gung-ho surgeons who will say, yes, I'll take it on, I'll give it a crack. But the reason that they're gung-ho surgeons and the reason that there are a few places that are doing it is because it's not particularly efficient. And more often than not, even with that local surgery, people are still going to fail with the prostate cancer coming back somewhere else. So you've gone through that major surgery, you've run the potential for wearing two bags, and it was all for nothing, because you've got the prostate cancer come back somewhere else anyway. So generally speaking, if the PSA starts to rise after a course of radiation treatment, we'll watch it for a few years, and then once it gets up to a certain level, then we start with the hormone treatment. That hormone treatment can hold it for a few years. The number of years depends on the aggression of the cancer. And now we've got, coming through the pipeline, half a dozen different drugs that are all looking extremely promising in terms of different treatments before we get even to the chemotherapy arm. And so now, whereas previously people were talking about 1 to 2 years of survival once you'd stopped having hormone treatment work, now we're talking about 4 and 5 years and more of average survival once the hormone treatment doesn't work anymore. So if you've watched it for, you know, you've had your treatment, 2 or 3 years later your PSA starts to rise again, 2 or 3 years later you start your hormone treatment, 2 or 3 years later you start the next line of tablets following on from hormones, you know, you're still 10 years on. You've still got 10 years of you know, reasonable quality life before the cancer is actually going to come back and get you. And you've got plenty of opportunity to die from other things first. So, you know.
That's very encouraging.
So I'm kind of cognizant of the time, and I'm kind of racing through to try and make sure I've got answers to all your questions. Are you comfortable with the level I've been throwing these answers at you?
Yep, sure. You're coming back to side effects?
Yeah, absolutely.
No, it's going well.
Okay. Okay, so when don't you want to? I think basically relates to the irritative symptoms that the person's got. I haven't mentioned sex life. I haven't mentioned sexual function. Forgive the crudities, but if you're getting sex at Christmas and on your birthday, then really talking about whether or not you're going to carry on doing much is kind of a bit arbitrary. So if you've got a partner who's not that interested, then you're kind of pushing the stuff uphill. So you really need to be able to discuss with your partner just how important the sex life thing is. Yes, of course, talk with your doctor, talk with me about what you feel about the whole process, but quite often wanting to do something and having the opportunity to do something you know, are two different things. Following on from radiotherapy, following on from surgery, it's quite good to continue with physiotherapy for the dick. It's quite good to to take a tablet to give yourself an erection once a week. The problem with doing that is what the hell do you do with it once you've got it? And so this, this is something you've got to work through and think about and take forwards as part of that. But if you are sexually active and happily, regularly sexually active, the likelihood of continuing to be sexually active following brachytherapy is terrific. And with an average age of 69, with everybody getting 6 months of hormone treatment, I found that 2/3 of my men were still sexually active 2 years later. So it's not something that goes overnight like it does with surgery. It does fade away with time. And I stopped looking after 2 years. I'm sure that with time that number is going to change, but people are getting older as well. So there's other things that step into life as well. It stops becoming quite as crucial as you sort of move through your 70s. So certainly the younger people, the younger you are, the more likely your activity is going to continue, and that certainly holds true. Other side effects, well, the same analysis that I did on my patients, I looked at the likelihood of continuing on and being and having side effects, and I went out to 10 years with mine. And if you grade side effects as 1, 2, 3, 4, well, sorry, 0, 1, 2, 3, forgive me. 0 is no side effects at all, perfectly happy, it's exactly the same as it was before. 1 is it's mild, it's a little different to how it was, but I can manage it, I don't need to do anything about it, I'm perfectly happy. I recognize it's different, but it's not appreciably so. 2 is, yes, it's different and I need to take pills, I need to do something about it, it's interfering with my quality of life. And 3 is, I've been to see a surgeon, I've been to see someone to have some form of interventional repair of this particular problem. So you can look at gut side effects on the bowel, on your bowel habit, on frequency, looseness, sloppy motions, bleeding in the backside, or you can look at bladder with frequency, urgency, blood in the water, as those are sort of potential side effects. With both of them, that's my 0 and 1 combined, and that's my 2 and 3, with that being 5%. So for the most part, you should be able to get away with very little in the way of significant side effects. There are going to be some people that have problems, and if they do have problems, those problems can occur either consistently or they can come and go across the years. But generally speaking, if we can get the brachytherapy dose in the right place, then we have a reasonable chance to keep the side effects down and tolerable. The issues for me with brachytherapy side effects are the frequency and the getting up at night, the nocturia, with the bladder, and the consistency of the motion and the number of trips to the toilet. And someone who's getting up more than 2 or 3 times of a night, I think is likely to have disturbed sleep, and as such I think it's worth taking a tablet to try and assist with that. So I'm more than happy to get someone started on Flamaxtra or Enable-X, or Vesicare is another one, to try and help with the bladder irritation if they're getting up 2 and 3 times of a night. Through the day, most people have no great dramas. Urgency can occur. Incontinence is uncommon. Incontinence, I'd say perhaps about 1% or thereabouts. It certainly can, less than 1%, it certainly can happen, and I've got a couple of people who are unhappy with that. But I think that they were also sort of up around the 15 score up in the first place. So I think they were sort of heading, wafting up in that direction, and I made the wrong call in saying, yes, we can do this, when I should perhaps have said, no, you know, the irritative symptoms are a little bit getting up there, maybe we should, you know, look at alternative ways of dealing with it. Pelvic floor muscle exercises really work. They are such important things. And consistently I get men who say that they're getting a bit of a dribble, they're getting a bit of urgency, and I say, you're doing your pelvic floor muscle exercises, and they say, what are they? And I said, well, don't you remember we talked about it? Oh yeah, that's right, I can't, no, I'm not doing them. You have to do pelvic floor muscle exercises. If you've got prostate cancer, regardless of whether you've had surgery, regardless of whether you've had radiotherapy, regardless of whether it's external beam or brachytherapy or seed, pelvic floor muscle exercises are so useful. So useful. I'm going to be crude because I think it's the most effective way of dealing with it. It's not sitting there in the yoga position, meditating, staring at your nasal and shrugging your shoulders. Imagine you're in a room, you've got your wife on one side of you, you've got the chaplain behind you, you've got your bank manager and your boss standing around you. Are you going to fart? And the answer is no, you're not. You're going to do the right thing and you're going to squeeze it in. And you can squeeze it in and no one's going to see you doing it. If you're sitting down at the table, no one's going to see you jiggling in the seat. If you're standing up, they're not going to see you twitching your pelvis or anything like that. You're just going to quietly squeeze your pelvic floor. Now, as you're all sitting there in your chairs, as you're squeezing your sphincter, you should be able to feel that you can lift your anus up off the chair seat. And it just lifts up. And I should be able to not know whether you're doing it or not because none of you are actually moving your shoulders. All right? If you're moving your shoulders, it's the wrong one. If you're moving your stomach muscles, it's the wrong one. This is secret women's business. The women know all about this. All right? Women are taught at an early age how to deal with this, and it's not something we've ever had to bother to stop and think about. But we haven't got there yet for the men. That's only the start of it. That's the back half of your pelvic floor. As you squeeze that sphincter of yours, can you feel as you're squeezing it that it's making your dick twitch? Can you feel that it's making your penis move, that the scrotum has just got a slight contraction there? That's the pelvic floor muscle exercise that helps control your bladder sphincter. So it's the front portion of that pelvic floor that you're really trying to work on. And 10 of those when you're brushing your teeth morning and night. If you're loading the dishwasher, you can do 10 while you're loading the dishwasher. If you're watching your partner load the dishwasher, you can do 10 while she's loading the dishwasher. But point is, there's plenty of opportunity through the course of the day to do 5 or 6 reps of 10 of those. Now, there's a fantastic lady,
Pauline Shirelli.
Pauline, and I was thinking of Tara is the other one.
Tara Katz.
Katz.
Taryn Katz.
Taryn Katz, thank you. There are some fantastic ladies, physiotherapists who will show you, will spend a lot of time with you if it takes more effort than that. But the bottom line basically is, if you work on your pelvic floor, it will help enormously with your bladder control. And if you manage your bladder control, then all of a sudden, some of those side effects suddenly start becoming much less of an issue. So we can certainly cause side effects, we can certainly create problems, but in actual fact, there are workarounds that are very effective in dealing with a lot of those problems. Bleeding is not something that you can work around. Bleeding is not something you can particularly fix. A smear of blood on the toilet paper, a drop of blood as you start your wee is certainly something that can happen. If it's a smear of blood on the toilet paper, I'm more than likely to pat you on the back and say, there, never mind. But if you're bleeding regularly from the backside, then I'm going to want you to go and have a colonoscopy, because it's more likely there's something else going on than it is the radiotherapy. It might be a hemorrhoid, it might be a tear, but it might also be a polyp and a little bowel cancer that's growing just as a separate issue. So bleeding from the backside needs to be monitored, followed through and checked. Bleeding from the bladder, bleeding from the front when you're having a wee and there's blood in your water, yes, it's certainly possible. I'd say the likelihood of radiation with the brachytherapy causing bleeding is probably of the order of maybe 1 or 2%. It does happen. But I will certainly want someone to have a look up inside your bladder to make sure that you don't have a bladder cancer, that we're not blaming the radiation for something else that is quite different and also needs treatment and dealing with. If the blood is at the beginning of the flow and then you've got a nice clear stream afterwards, that's more likely to be from the prostate. But if it's mixed in with the stream and it carries on the whole way through the flow, then it's more likely to be coming from the bladder, and I'll particularly want someone to have a look up inside and see what's going on. You can get a narrowing of the urethra. A narrowing is called a stricture. So there's your prostate, and your urethra is coming through. Most strictures happen down here. They don't happen in the prostate. If it's down there, that means that the radiation dose was down there. And my concern about that is that it means that where the person gave the brachytherapy didn't give the brachytherapy in quite the right place. My stricture rate, pleasingly, is quite low. With that, I'm frantically touching wood. But my stricture rate is quite low. We spend an awful lot of time making sure that when we're doing the treatment that we're trying to make sure that we've got the dose of radiation where we want it, and not that the needles have slipped out 5 millimeters or a centimeter and we're putting dose lower than we should be. But if you do get a stricture, it needs to be dilated up. It needs to be stretched up, and that's a surgical procedure. The urologist needs to go in and dilate it up. And so that's certainly something that needs to be done. And it may need to be done several times. And they need to be fairly gentle about it, because obviously if you've got some scar tissue there and you're a bit rough, you can create more scar tissue and you can repeat the cycle. So you just need to be careful with strictures. A fistula is seriously bad news. A fistula is where you've got a connection between the rectum and the urethra, or the bladder. So a fistula implies that there's been an event where the tissue has suffered from the radiation dose, and then a second event has gone in that has resulted in some form of ulcer occurring that has then eroded forwards. The likelihood of causing a fistula with brachytherapy is of the order of 1 in 1,000. And if we can train the colonoscopist, the person doing the colonoscopy, not to biopsy that bit of the rectum, we can drop that incidence to 1 in 10,000. So 9 of 10 fistulae are caused by the colonoscopist going up with his telescope and saying, oh, look, there's some scarring there. I wonder what that's from. I'll take a sample of that. And they take a divot of the rectum, and that leaves a wound, and that wound turns into an ulcer, and that ulcer deepens, and all of a sudden you've got a perforation. So if you go and have brachytherapy, and you then, some years later, need to go and have a colonoscopy for whatever reason, you must tell them that you've had a high-dose radiation treatment, so that they know not to biopsy that bit behind the rectum, behind the prostate. It's only an area about the size of a 20-cent coin. It's not a big area that they need to protect, to avoid. So if there's a polyp sitting up here, or there's a polyp over here, you know, the world is their oyster. But it's that particular portion there that they just need to be a bit more careful about. The other rare event is second cancers. Any form of radiation can cause cancer, so the potential is there for a course of radiotherapy into the area causing a cancer as well. And the likelihood, it depends very much on who you talk to. The likelihood of radiation causing a cancer is somewhere between about 1 in 200 to 1 in 5,000. The radiobiologists, the international experts, would agree that a usable figure, a workable figure, is 1 in 1,000 as a lifetime risk, with that risk spread between, say, 5 and 15 years from the time of treatment. So it's a low risk. 1 in 1,000 is the same sort of figure that the anaesthetist will use to tell you that there can be a complication from their anaesthetic for the surgery as an equivalent. So it's not a particularly big risk. On the other hand, if you don't like the idea of a 1 in 1,000 risk of a problem in 10 years' time, then you have the alternative of going for surgery instead, or using hormones. I guess one of the points there is you've got to be there in 10 years to get it. So, you know. That's pretty well. Lethargy, tiredness. I guess one of the points about seeds is that everyone thinks because it's a convenient treatment, because it's a one-day treatment, it's therefore an easy treatment. It's not. It's a full-on cancer treatment. It's just the fact that we get the treatment over and done with in a day. You're still going to wear 2 months of side effects. You're still going to wear 2 months of the irritation from the radiations. It's coming out of the iodine seeds and going into your prostate, with the burning and stinging and the frequency, with the irritation, the altered bowel habit that can go with that, and the tiredness that can go with that. So a course of radiotherapy, be it external beam or be it brachy, you'll get some tiredness at the end of it. How tired? As tired as you want to be. If you're busy running around like a headless chook trying to keep everything going, you'll be able to carry on doing that. If, on the other hand, you've got the opportunity to drop everything and say, I need 2 months off, then that's not a problem. I'm more than happy to write you a 2-month certificate to say you need time off because you've had a cancer treatment. It really is a question of what suits you, what you feel is necessary, what you find you can and can't do. And, you know, your own psyche is going to have an impact on that. What's happening in your life is going to have an impact on that. And all of these things will interplay. But as far as external beam radiotherapy, I think that people get as tired from the fact that it's going backwards and forwards every day for several weeks, and the traffic and the driving backwards and forwards and the 2 hours that it takes, not the 5 minutes of treatment. I think all of those things have as much of an impact on your tiredness as the actual radiation treatment does. What I have heard consistently from people who've gone through radiotherapy, and not just for the prostate, is that the days that you have that you're tired are just as tired 6 months on as they were whilst you were going through the treatment, but the number of good days increases. So you have good days and bad days, but the bad days are just as bad. They just get less and less frequent as they occur. So recovery, most people are back and functioning fairly efficiently. I routinely want to see people a month after they finish their treatment, and the reason for wanting to see them a month after is to make sure that they're 80 to 90% back to where they were before they started, and that they can see that there's a trend improving, that there is a trend happening, that they are getting better. And if that isn't happening, then we'll talk about what we need to do to try and get that happening for them. But there's an expectation that by a month afterwards they're pretty well better than they were before they started, or as good as where they started. I think I've covered most of those things. Cost. I work in the private system. I don't work in the public system. If you can get your brachytherapy done in the public system, it won't cost you a bean, unless they choose to treat you as a private patient, in which case I don't know what they charge. The total cost is probably upwards of about 25,000, of which Medicare will pay for a third, your health fund will pay for a third, and you're out of pocket about 8,000. About. That depends a little bit. I'm using, in using those figures, I've taken an estimate of what the surgeon's going to charge. I've taken an estimate of what the hospital and what the anaesthetists are going to charge, and I've included all of those in that figure. So that's about the sort of figure that it would cost in the private system here in Sydney with us. I don't know about the other private units elsewhere.
Yep. Can you just wait until we bring a microphone to you, please?
You just use the microphone.
Use the microphone.
So I just wonder, is there any hospital that treat as a public patient for this brachytherapy in New South Wales?
Yes, there are. They all do, but they all are very heavily rationed. And so it really is a lottery as to when you go and what's available and what is and what isn't. For instance, at St George, they have, I think, something like 50, they're allotted 50 seed patients a year that they're allowed to treat by the New South Wales Health as a public patient. So, you know, if you're there at the beginning of the year, you're okay. If you're there at the end of the year, you've had your luck. So it just depends. You're going to have to ask the hospital, not me.
Yeah. So it looks like it's question time.
Well, no, not yet. I haven't answered the final one, which is the complementary. So what can you do? What complementary things? Well, I guess you do what you're comfortable with is the answer to that. In terms of diet, the belief is that a heart diet is a diet that is good for your cancer, is a good for you to deal with your cancer. So eating a lot of vegetables is good for you. Eating fish is good for you. Eating less red meat is good for you. It's interesting because I'm not completely convinced that it's not so much what you're eating as how much you're eating. There's the classic argument is, or the classic story is the Japanese ladies who went from Japan, migrated from Japan to America. And the first generation, the women who migrated in their middle ages, that went across to the US, had the same incidence of breast cancer as their peers back home in Japan. Their granddaughters had the same incidence of breast cancer as the American women, and their daughters were halfway in between the two. And so we don't know whether it's that there's something wrong with the Western diet that we're consuming that we shouldn't be consuming, or that there's something right with the Japanese diet that we're not consuming when we should be consuming it. So we don't know if it's green tea is good for you, or if the fats are bad for you. But what the suggestion is that it's the quantity of the American diet is way over the top compared to the quantity of the Asian diet. And so what we're doing is we're actually eating too much. And so being overweight is not good for us, and this is the pot calling the kettle black here. It's more a question of the caloric intake, and that's probably why the Mediterranean diet is good for you, because there's lots of vegetables and less of the fatty foods, and so that might be why that one works. So diet is one aspect of it. What else? Antioxidants. People argue that antioxidants are good in helping combat these things. I don't know is the answer, and we will never know, because the problem that we have with that is that you would need to have studies with hundreds of thousands of people in there, and everybody has a varied diet, and there are multiple different factors. Was it the antioxidants you had in the last 2 years that are relevant? Was it the antioxidants that you had 10 years ago that are relevant? Is an antioxidant intake after your diagnosis of prostate cancer going to be any different to an antioxidant intake prior to your diagnosis? So there are too many variables. We won't know the answer to that one. The selenium vitamin E study showed that selenium had no advantage and vitamin E didn't have any great advantage. In fact, I think there was a cardiac risk with that study. So selenium and vitamin E don't look to be particularly helpful with managing prostate cancer. Was it pomegranates? Pomegranates are one of the things that are currently being argued, and there's quite an industry getting up and going around the pomegranates. I haven't seen the literature on it, but if you're happy to drink pomegranate juice, then I don't see why it should hurt you. So absolutely, by all means, go for it.
Just to regard this,
Hang on. If you want to ask a question, please.
just regarding the selenium, recent reports have come out that study that you saw was they were using synthetic selenium. If you use natural selenium, you get better results, and tests have proved that.
Fine. I would have thought selenium was selenium. I would have thought that the substance was the same. So I don't know the answer to that question. But again, I think you're running into very small numbers, and I think that you're potentially up against people who have a particular barrier to push. If you're happy to take the stuff, then I certainly wouldn't stop you from doing so. Snuffy Myers, Charles Snuffy Myers is a guy in the States, he's a physician in the States who got prostate cancer and got heavily into the whole thing, and he's a great believer in the diet, he's a great believer in exercise, and he has a fanatical approach to what you do in your life, and if that's for you, then I'm not going to stop you from doing it. But personally, I'm a believer in moderation. I think that there has to be a role for quality of life in the process of what you want to do. But he certainly had a reasonable argument for trying to do things. So I think you perhaps read his book and pick out of it what you want to pick out of it.
What are your thoughts on the overdiagnosis and overtreatment of prostate cancer, particularly against the literature that's being published on a daily basis now, particularly for low and even intermediate rate.
Sure. So what we need to do is we need to actually break the link between the concept of having prostate cancer and treating prostate cancer. Because unfortunately, society has driven us into this situation where being told that you have cancer, you have to do something about it. And that's not necessarily appropriate for prostate cancer. And it's certainly, it would be reasonable to say that someone with a small focus of Gleason 6 prostate cancer could be watched quite happily for many years. So there have been studies, observational studies, that show that Gleason 6 is not a particularly unpleasant disease. There's a guy called Albertson who did longitudinal studies on people managed with observation, breaking it down by Gleason score. If you've got Gleason 8, 9 and 10, that's not a smart move. If you've got Gleason 7, you're probably looking at the quantity of 4 in that Gleason 7 score, and again you can argue the toss on that one. Gleason 6, there's something to be said for observation. Problem with observation is that after 2 or 3 years of observation, most people get sick of waiting for something to happen. And it's actually very difficult to live with a concept of ongoing observation. It doesn't mean you can't do it, but it does require a certain mindset. And it doesn't just require your mindset, it requires your partner's mindset to be in tune with that. Because, you know, men can be perfectly happy to do nothing. Okay, that's fine, there's a bit of a problem, all right, well, we'll watch it, we'll watch it, we'll watch it. Problem with that can be, and I'm not saying it will be or it is, but it can be, they've got a partner or a sister. Why haven't you done something about your prostate cancer yet? When are you going to do something about your prostate cancer? And in the end, you know, they just buckle under. And the other aspect to that is that it's all very well having one specialist say, no, I think we can afford to watch this. I think this is not a problem. I think you want to carry on watching it. No, you go and find there's no dramas. Your PSA is not moving. You know, there was only a small focus of prostate cancer there. People choose to go for a second opinion. And it's easily interpreted as, I'm not happy with my initial management decision. I want to do something different. And it can be quite easy for that second opinion to say, well, you know, observation obviously didn't work, or interpret it as observation didn't work for you, let's offer an alternative. And so people get sucked into that process. And so, yes, absolutely, what we need to do is we need to break the link between a diagnosis and actual management. And observation is perfectly reasonable for a particular group of those people. Yeah.
John? Bruce, you're next.
Is there any sort of prophylactic effect of doing, you know, really keeping up with your pelvic floor exercises? Because, you know, as time gets on, most people start to develop more and more risk of incontinence.
Yes.
Yes,
absolutely.
Right. So there's evidence, isn't it?
Oh, I've not looked for it, but
No.
it makes sense.
Oh, yes, yes.
You know, there's no evidence about parachutes.
All right, but it's a lot of squeezing. Yeah.
It's not difficult. It's not difficult to do it.
No.
You know, I mean, you brush your teeth every day. There you go. There's nothing to stop you doing 10 squeezes whilst you're doing that. Nothing at all, except the mind games in the back of your mind. Oh God, have I got to do that? You know.
I've done 10 listening to you.
You know.
Thank you for your talk so far. Suitability. Back 9-10 years ago when I was diagnosed, my thyroid deficiency referred to iodine, and therefore that probably brachy would not be appropriate. Is that still the case?
No. Different thing altogether. The iodine that we use for seeds is iodine 125 that's soaked onto a ceramic seed that's then wrapped in titanium. So there's no contact, there's no direct contact with iodine on you, in you. So, no, it's completely separate animals. Good question, though, thank you.
Another question?
As part of trying to look at doing active surveillance, part of that would be a biopsy perhaps every 12 months. Is there a different...
Not necessarily every 12 months. After the first one, yes, 12 months would be a reasonable time for the second one. But if that one's good, then you might even look at 2 years for the next one.
Right.
So not necessarily 12 months. 12 months for peace of mind, maybe, But if you got Gleason 6 the first time round in 5% of one core, and the second time round you get Gleason 6 in 5% of one core, you might easily say, well, in fact, what we'll do is in 12 months' time, we'll look and see what your PSA has done. And if that hasn't changed in that 12 months, we'll skip that one. So you don't necessarily need to.
Is there some other procedure by way of an MRI, sophisticated MRIs, that might avoid the actual biopsying but having reasonable certainty?
MRIs are a hot topic at the moment, and it depends very much on who you talk to. It depends on who you talk to, because the radiologists that have got the gear, that have got the nice 3T machines and aren't using the rectal coils and you know, can charge you $600 a pop, are saying yes, you can use them as diagnostic. And I think the jury's probably still out just for another 2 or 3 years. People are looking, people are very keen to try and come up with an answer on that. And so I think we will have an answer, but not yet. And I've got my finger on down here, because the other thing I wanted to say in terms of looking at observation, there's nothing wrong to be taking finasteride as part of that observational process, because finasteride is an alpha reductase inhibitor, and it may well have an impact on the prostate growth, and potentially avoiding or slowing down the prostatic malignancy as well.
Potential remission?
Yes. So the studies, I think, are on protection, but we're not sure just yet as to whether it's actually a therapeutic or not. It may be that for that low-grade Gleason 6, a low-volume disease, it might be helpful there. It might just be that it helps the sampling process. There's a story about using it actually gave rise to higher grade cancers. But when they dug a little bit deeper into that, what they found was that it was just a sampling, that the prostate itself was a smaller volume, and so they were getting a better idea of what was going on. So.
Any more questions?
Have I numbed you and stunned you? Yes, sir.
One more over there, and then one more here.
I mean, if you're offering, you know, choice that you are having brachytherapy and surgery, what would you recommend patient to choose if?
Your choice. They are effective treatments. I'm a believer and a follower of the grim data that you will not lose by choosing brachytherapy in terms of long-term results. But what are your symptoms like? You know, what's your flow like? How are you going at the moment? Are you getting up 2 and 3 and 4 times of a night? Are you having problems with your waterworks? If you don't have any problems at all with your waterworks, then there's no reason why brachytherapy couldn't do a good job for you. Flip side of that is, if you've got problems with your waterworks and your quality of life is dodgy, then why not have surgery in that situation? Why not fix the 2 birds with the same stone? So it boils down to, some people run screaming from the idea of a knife. Some people run screaming from the idea of radiation. It's your personal preference. It's what you're comfortable with. You're the one that has to make a decision that you are going to live with for the rest of your life. I'm only going to see you for 15 minutes once a year, you know, and want you to tell me that you're fine and you're happy. But you're the one who lives with it on a day-to-day basis. Which one are you comfortable with? And the best way to answer that is to sleep on it. You collect all the information that you want, all the information until you believe that you've got enough information you can't take on anymore, enough is enough, and then you sleep on it. That night, doesn't matter what night it is, that night you say, I'm going to have surgery. See how you sleep, see how you feel in the morning. I had a good night's sleep, I'm comfortable with that. The next night, I'm going to have radiation, I'm going to have external beam. Sleep on it, see how you feel with that. The next night, I'm going to have brachytherapy. Sleep on it, see how you feel with that. You do that for a week, your mind will be made up by how you feel after a week. What we are offering you is we are offering you alternate ways to deal with the problem. We are not offering you the only way to deal with the problem. We are saying that there are 2 or 3 or however many, 2 different ways of dealing with this particular problem. Which one is your preference? So that you're not going to make a wrong decision. What you've got to do is you've got to choose the decisions that are right for you. You know, it's not intellectual. The supposed intellects of the medical profession, and you've got to wonder about that. The supposed intellect.
Stop laughing.
The supposed intellects of the medical profession are supposed to have agreed that they are at least equivalent in terms of their results. And if they do that, then what they're saying is that you've got treatments that are going to be equi-effective. It's just a question then of what side effect profile can you live with? What suits you? What are you more comfortable with? One thing on seeds that I didn't mention, and I'm sorry, because they're radioactive, there are certain radioactive precautions that you've got to take into account. So if you've got a young family, if you've got children under 16, then you shouldn't have them sitting in your lap for 3 months after the seed goes in. They can be in the same house, no dramas, but they shouldn't be sitting in your lap for 3 months. You should have sex with a condom on so you don't drop a seed into your partner. The law says that you should pee through a tea strainer so you don't drop a seed into the sewage system, although who's going to know that? And the law also says that you're not allowed to be cremated for 12 months after a seed implant. But, you know, what are you doing dying on me? So there are some radiation safety principles that are involved there. But these things are all these things you need to take into account to be able to choose the one that you're comfortable with, your gut, your heart feeling. It's not an intellectual decision.
What about age? Age? Do you take
What about age? Why should I be ageist? Why should I say that this 80-year-old man who is fit and can walk 10 kilometers a day shouldn't and is likely to live 10 years should not get a treatment when this 66-year-old man is coughing and wheezing just coming through the door? You know, age is not relevant. It's the quality of the fitness of the individual. The long-term studies, that data I showed from Grimm, the only data that went out to 20 years was brachytherapy data, because the surgeons and the external beam radiation oncologists stopped collecting it after 10 years. So, and the figures out to 20 years were better, were consistently good. So age doesn't need to be a part of it particularly. Having said that, is it important to you? Do you want, you know, what do you feel more comfortable with? You know, do you feel more comfortable with the idea of removing it and having it gone and then dealing with the problem if it comes back? You know, you've got to make that call.
We've got time for one more question. John, did you want one?
Just to elaborate on hormones, because we know all about hormones in terms of the females, but not so much about the males.
Okay, so hormone treatment is not a curative treatment for prostate cancer. Hormone treatment is a controlling treatment. You're looking to control the growth of the prostate, or the progression of the prostate cancer. So you can use it in the adjuvant setting. You can use it in conjunction with radiotherapy. It's not usually used with surgery. You use it in conjunction with radiotherapy to shrink the gland down, to make the volume smaller, or you're using it in the controlling situation after your local treatment has failed, or in the person who wasn't fit enough for local treatment in the first place. And how long it works for depends on the aggression of the cancer. So someone who's got a Gleason 9 or a Gleason 10 prostate cancer is more likely to develop hormone resistance after 2 or 3 years than someone who's got a Gleason 6 or Gleason 7 prostate cancer who may have control of their disease for 10 years with hormones. We've now got multiple different agents that you can almost cycle through, and quite often what people will do now is they will cycle through the different types of anti-hormone treatments. If this one stops working, you move to this one. If this one stops working, you move to this one. You move back to that one. So you're giving them a bit of a rest. Well, there's the LHRH agonist, and there are 4 different LHRH agonists. There's the anti-androgens, and there's a couple of those. And I think there's a couple of other new ones that are coming in that are still in trial at the moment. It'll drop back into my memory about 2 seconds after we finish. But there are several of them. And the other thing is that you can look at doing is coming off the hormones and having a break from the hormones. So that's called an intermittent program. And so there are different ways of dealing with that. And so you can usually control with hormones for 5 years or thereabouts. So it's used in the controlling setting after the primary treatments failed, but it certainly should buy a significant period of time for the individual. What it is hormone treatment is a polite way of saying castration. It's switching off the testosterone. It's rendering the testosterone non-functional. The injections stop the production of testosterone. The tablets stop the action of the testosterone, which may be relevant because in the younger man, that means that they can still keep their libido, or they have a better chance at keeping their libido and a better chance at keeping their erections. And if they've got an active sex life, that's usually more attractive. Downside to the tablets is that there's an increased risk of shortness of breath and lethargy, and in a small number of people, liver toxicity, hepatic toxicity. So you need to be a little bit careful and watch that. So
Okay. There is one more up the back there.
How you
sorry,
going?
you've been waving for ages, have you? Sorry about that.
Taking it all in. After having the brachytherapy treatment and external beam radiation,
Yeah.
and then contracting bladder cancer,
Yeah.
how long ongoing, because I've been told that once you have a tumour removed from the bladder, then 2 can pop up, then you get those out, and then 3 or 4 pop up. How long is that ongoing for?
How long is a piece of string?
Really?
It's different from person to person. I mean, it's a rotten situation to be in. A combination of bladder and prostate cancer together is really, collecting the Black Queen and the Ace of Hearts as well. But it's difficult to know exactly how long that's going to happen because it depends very much on how long it takes between the first episode and the second episode, and between the second episode and the third episode. And is that interval shortening or is that interval lengthening? And so you're only going to find that out by walking the walk. The answer is probably years, but how many years varies from person to person.
Okay.
Thank you.
Well, Michael, I think we better wrap it up now to let you get away. But I would like to say on behalf of everyone, thank you again for a most informative session. These are always very sought after, and tonight was no exception.
Thank you.
Excellent questions and answers, and I'd like you to help me thank Michael for coming.
Thank you.